Pull it up here. So I'll get started. My name's Dr. Kwon. I'm one of the trauma surgical critical care fellows over here at Ryder in Miami. Today we're going to talk about a case, left thoracoabdominal GSW. So some objectives are to discuss injury patterns and management strategies of left thoracoabdominal penetrating injuries and to review peritoneal resuscitation, utility, and technique. So we got the call from EMS. There was a 70-year-old gentleman with a gunshot wound to the left upper abdomen. He was reportedly hemodynamically stable, GCS 15. When he arrived, he was complaining of some shortness of breath. In the trauma bay, we started with our ABCs as usual. His airway was patent. He had bilateral breath sounds. Heart rate was 60s. Blood pressure was 137/92 initially. He had palpable distal pulses. Again, he was a GCS 15, and we noted left thoracoabdominal and left mid-back apertures as shown in the image. We did a cardiac fast, which was negative. His remaining exam was significant for just difficulty overall, as patient was wide awake, but he had some diffuse guarding, but would only endorse tenderness in the left upper quadrant. He had a persistent normal sinus rhythm, but had a decreasing blood pressures with SPPs dropping to the 90s to 100s from the initial 130s. So we transfused him a unit of whole blood, and we placed a left chest tube, which had about 300 cc's of sanguineous output. We got a chest x-ray in the bay, as you can see here. We did note this bubble over here that was concerning for a diaphragmatic rupture or laceration. So what next?
Okay, so why don't we go ahead? Actually, Dr. Valenzuela is here also. Okay, people, I don't see some of our usual suspects. Maybe I'll start with Supra since I haven't spoken with him in a while. Supra, what would you do next in this case?
Thank you. I think this patient needs to go to the OR. He's in shock and he has bleeding somewhere. The tube output was only 300, but he had a thoracoabdominal gunshot and air bubble on the left chest on the chest X-ray. So I think I would transfer him to OR, and I would start with ELAP. This guy put him in a supine position, but also I'm gonna practice chest for possible thoracotomy. Thank you.
Okay.
Thank you, Supra. Go ahead, Eugenia. Why don't you continue?
Yeah, so, we thought about the scanner, but especially with the chest x-ray and the worsening possibility of like shock development, we ended up going to the OR. We started with our exploratory laparotomy. Our initial findings were left upper quadrant hematoma. We noted as the stomach was herniating through a left diaphragmatic laceration. There was a through and through injury to the spleen, along with the distal transverse colon injury. Of course, we examined the entirety of the peritoneal cavity and ran the entirety of the bowel. We noted contamination of stool in the abdomen and some in the left chest as well. From there, how would you proceed?
I'm going to make a general announcement trying to get Carlos Quispe's attention again. Carlos Quispe. Sorry, guys, I'm trying. Right. I am not in a page, I cannot get everybody's name up here, so I apologize about the, not calling on everybody. If, Dr. Fraga, would you like to respond at this time? Do you have your next step?
Yes, thank you. So the patient was stable at this moment or not?
So he was requiring continued transfusion. Not very, again, never really developed much tachycardia, but did become hypotensive, responding to some continued resuscitation.
Okay. Is there active bleeding from this spleen?
There was some bleeding from the spleen, yes.
So I think you need first control the bleeding, probably splenectomy in these patients. So you need to repair the colon injury, no ischemia in the colon, only a transfixed injury in the colon.
So the colon was, I think it was greater, the edges, it didn't have clean edges for the colon injury. So we decided not to do an actual repair. We did a resection instead.
Okay, no injury at the stomach. Only
No.
the stomach was in the chest, but without injury.
Correct.
Perfect. So bring the stomach to the abdominal cavity. You need to repair the colon, the diaphragm, but it's very important, clean the abdomen and clean the chest.
Mhm.
It's a logical solution. You need to clean before close the diaphragm. For a chest patient, you have many contamination, can put a second chest tube, but very important, clean, drain the chest, and I think it's this at this moment.
Yeah. So that's what we did. We ended up doing the sterotomy. We copiously irrigated the chest, several liters of warm irrigation until it was clear. We didn't see any active blood pouring out from the chest afterwards. So we did the primary repair of the diaphragm. There were actually 2 lacerations. And then we did a partial colectomy. At this point of the case, he had received a total of 3 units of whole blood, 3 units of PRBCs, 3 units of FFP, and was requiring intermittent vasopressin. So now what?
Dr. Polo, are you available? Sorry, Jenya. Dr. Farina. Okay, Eugenia, why don't you tell us what you did next?
All right.
Trying here, sorry.
It's okay. So what we ended up doing, I guess the questions that we had was, is there anything else to do for the contaminated chest wound management, contaminated wound management, anastomosis for leaving in discontinuity, closure. So for us, after all the copious irrigation, we did the diaphragm repair, like I said. We ended up leaving the patient in discontinuity, placed a drain at the base of the mesentery for EPR, and then we did a temporary abdominal closure. The decision to do this was a combination of things. Again, he was 70 years old. He was requiring quite a bit of resuscitation and would likely require more and post-operatively. So all those things played into our decision making for leaving the patient open, discontinuity, and initiating EPR.
Sorry, Eugenia, I can't even hear you. And I'm. Go on.
All right. So now what? So what we did next, we ended up going to the scanner post-operatively to rule out any pseudoaneurysm in the lung. There wasn't any. He ended up having some root fractures on the left, 6, 8, and 9, along with the left lung contusion, and then he was taken to TICU for further resuscitation and DPR management. So just briefly, when it comes to direct peritoneal resuscitation, you know, we use it as an adjunct of IV resuscitation. Essentially, it's targeted resuscitation of the splanchnic microcirculation. It's thought to more rapidly reverse vasoconstriction and hypoperfusion at the PU level. Ideally, it reduces local inflammatory cytokines, preserve endothelial cell function, and hopefully mitigate organ edema and the necrosis process. So,
Carlos Quispe. Carlos Quispe. Does anybody have his contact information that they can contact him directly? His mic? Sorry, Kenya.
it's okay.
Okay.
So anyways, the whole goal is, or the thought is that this could decrease failure to achieve primary fascial closure, the time to closure, and intra-abdominal complications. For those who aren't familiar, this is a diagram of one of the variations for DPR. It's pretty similar to what we did. There's a so essentially, you infuse a glucose-based hyperosmolar solution, like a dialysate, via a percutaneous catheter with the tip near the pelvis or the root of the mesentery. The abdomen's left open. There's a large extra-abdominal drains, and you can use some sort of negative pressure abdominal dressing, whether non-commercial or commercial.
I'm going to stop you right there. And since we have a lot of representation from other parts of the world now, just ask anybody, are other people using this frequently, DPR?
I have no experience with DPR here in Campinas.
Interesting. Thank you, Dr. Fraga. Supa, what about you?
First time I heard of it was in Miami 10 years ago. And I have never used one. And I thought that at that time when we were training in Harvard, no one had ever used it then. But I think it's very interesting to have this as an adjunct to help with resuscitation and decreasing the bowel edema. Thank you.
Thank you. And Sarah Ashley, it's great to see you. Who has a resounding yes with an exclamation point that she uses it. Sarah Ashley, do you wanna make a comment about it?
Yeah, I learned it in Miami, brought it to Jacksonville, been using it with a lot of success and kind of spread it around. More people using it here too.
Wonderful, thanks. Good to hear from you. Eugenia, do you want to say like what made you particularly think about it in this case and how often do we use it?
I'm seeing it more and more, but for us, part of it was the resuscitation that he was requiring intraoperatively, and you know, looking at the resusces that he had intra-op with his base deficit and whatnot, we knew that he would require further resuscitation, so that was part of it. The other component for deciding on this was the fact that he had some stool contamination as well, so we were hoping that the DPR would help with essentially like the contamination that was involved.
So almost like a Veriflow dilution. Okay, please continue.
Okay. So Like I mentioned, he went to TICU post-operatively, got further resuscitation, was off pressors, his lactate had cleared, so we took him back to the OR essentially like 30 hours later. Upon re-exploration, we found some murky fluid in the left quadrant. There was a little bit of saponification around the tail of the pancreas, and some of the soft tissue in the area. We noted that the distal limb of our colon resection, there was some contusion and maybe some possible ischemia. We actually ended up using ICG SPY to view our limbs, and it did look like that there was some diminished perfusion to like 5 centimeters of that distal limb. So the decision was made to resect part of that, or to resect that portion further. During the case, patient was noted to be an AFib, which was something that was newer, a new development. I think it had actually started a little bit preoperatively that morning, but it had recurred, and then he actually became hypotensive during the case. There was no bleeding that we found, so he was given amio and quickly converted to sinus, but was still hypotensive, so vasopressin was started. Basically, given all these findings with his hemodynamic status, and then his age again, and concern for maybe like a pancreatic contusion or whatnot with the saponification we found, we ended up just doing a washout, resected that distal limb, and then did a colostomy creation, and we were able to close. And then we also left a drain in that left upper quadrant and spleen. So he was taken back to TICU post-operatively. He had return of the AFib, so he was placed on an amio drip. He seemed to improve hemodynamically, but then Levofed ended up being restarted overnight the following day. Echo was done, which is unremarkable, and a patient was extubated post-op day 1, but required reintubation that same night for respiratory distress. The following morning, post-op day 2, from the closure, he was noted to be febrile with worsening chest x-ray. He was actually pan-cultured, antibiotics were brought in. We did a repeat CT chest, which did show some fluid at the base. At the left base, there was thought that maybe it's intrathoracic versus subdiaphragmatic. The decision was made, or the decision was made to continue non-operative management at this point for the chest.
Eugenia, can I ask you one quick question, and sorry to interrupt? It's a little different than our normal format. Earlier on, you mentioned that you took him post-operatively after the index case for a scan of his chest, looking for a pseudoaneurysm in the chest. Did I miss that, or did I get that correct?
Correct.
What was making you suspicious of that? First and foremost, that's not our usual algorithm. So what was the thinking there?
I think part of it was the fact that we didn't go into the chest either thoracoscopically or open. We did irrigate everything, but I guess there was still concern that there was some lung injury related to direct lung injury related to the gunshot wound.
Okay, but it wasn't that contusion, like volume of contusion or retained hemothorax, but specifically with the question of pseudoaneurysm, or?
I think it was all of the above.
How does that compare to now what we're seeing on this coronal cut?
So it was, I mean, there is some, yeah, I should have brought the image up. That's my bad. But the fluid in this repeat CT, there was a little bit more, but again, this is only post-op day 2. He never had a leukocytosis, so despite all of the fevers and the worsening chest x-ray. And I think ultimately the decision was made to not go for a VATS at this time.
Okay. Thank you. Thanks for indulging me.
Sorry, could I ask a question, please? Jaime Villaquiran from the UK.
Yes, of course.
Please, go ahead.
Thank you. It's that in most of these patients, you have contamination just by the gunshot entering. He had two entry points into the diaphragm, didn't he? And
Yes.
so it's quite contaminated. He had a lung contusion. Why not a VATS immediately at the start of the procedures? You could have finished all your abdominal and done a simple VATS, cleaned it all, washed it. And why wasn't it taken at that time? Was he so unstable that you didn't take it?
So yeah, he was, part of it was the instability, and then the other portion was that the laceration to, one of the lacerations to the diaphragm was actually quite large. We felt that we were able to irrigate and clean out the chest pretty well, and had very clear effluent by the time we were done with the chest. So yes, the decision was made not to do a VATS at that time.
Thank you.
That raises a good question. Is that part of your practice, always to do a VATS at the initial operation?
Yes, we always do a VATS and wash and make sure we've really closed all the holes of the diaphragm, and we can examine the lungs and the lung contusion. If there is any laceration or anything, then we can deal with it immediately. And we usually leave 2 drains when there's a big hole in the diaphragm. That's a big contamination. So we use 2 drains, one basal and one apical.
Yeah.
Thank you for sharing that. Let's go around then and
Thank you.
see if there's
Can I
practice
make a comment?
variation.
Joyce,
Yes.
just make a comment. Usually in gunshot wounds, there's no a critical contamination. Usually you can clean through the road, you can put a physiological solution, warm, and you can clean. But sometimes VATS is necessary in the first operation. I agree with the decision to put a second chest tube, because you can drain better than only one chest tube. But you need to pay attention on the evolution of the patient. If the patient will need a VATS, maybe at this moment, 48 hours later, it's very soon to perform a VATS. But in the evolution of this patient, probably you need a VATS.
Thank you, Dr. Fraga. Okay, go ahead, Eugenia.
Okay, so like I mentioned, we continued with the broad spectrum antibiotics. However, despite this, he actually developed a new leukocytosis, continued to be febrile, and chest x-rays, he had some worsening lung consolidation. Initially, we were successful in coming down on his ventilator support, but ultimately unsuccessful in weaning the vent. He also had noted worsening secretion, so a repeat CT chest was actually ordered on post-op day 5 enclosure. So here are some, here's the repeat CT that we ended up getting on post-op day. I think it ended up ultimately being post-op day 6 when it was finally done. As you can see, there's this persistent collection, slightly worse actually on that left base. The chest tube wasn't really draining it. So the decision was made to take him back to the OR for VATS at this time. So we started the case with our left video-assisted thoracoscopy. There was multiple areas of retained hemothorax and loculated collections. The lung was extensively adherent inferiorly with the large collection. However, he developed worsening hypercapnia with the single lung ventilation, and the decision was made to go open and complete the decortication. With this, 2 new chest tubes were placed, one at the apex and one at the base, and then bronchoscopy was also done by anesthesia at the time to help clear the extensive secretions. After this case, the patient was taken back to TICU from the OR. He's actually still in the ICU now. He's only post-op day 3 from his thoracotomy. At this point, he's continuing on broad spectrum antibiotics while we're pending the intraoperative cultures, and we're slowly weaning the vent at this time. Any comments or questions?
I'm going to just open it up for general questions. I mean, what is your take on it, Eugenia? Like, was it that you wanted to highlight the use of DPR on it, or any particular
Yes.
focus
So,
for?
yeah, so when I was actually asked to present this case, yeah, the focus was going to be more on DPR. Over the weekend, you know, this has been a progression with the VATS converted to open thoracotomy that had happened just after I had been asked to present this case. So I think the biggest question I have after all of this is what to do when the setting of this chest contamination. What could we have done? I mean, I think one of them would have been to place an additional chest tube at the index or at the time of closure, especially at the base. But is there a role for anything else, any other intervention or management for this patient? I was trying to look and see in the literature if there's anything else, but it seems to be up for debate on what's ideal.
I think one of the things to also consider is the timing, right? Of you said that you took him day 5 or 6 was when the scan was finally done, but seeing that CT scan, that cut that you showed us on day 2, would that have changed things, and that you would have been able to accomplish this with a VATS instead of open? So earlier intervention with those findings, I think, is a good question as well. Dr. Fraga, anything you'd like to add to that as well?
Yeah, I don't know if the DPR was a good indication in this case with diaphragmatic injury, because sometimes it can roast the contamination. But at this point, I think it's antibiotic and try to improve the patients.
Thank you. Dr. Sorry for the pronunciation, but Dr. Villakuran?
Yes, no, as you mentioned, thank you. It's the timing. As probably we've learned that in a big contamination, a big perforation, we'd rather do the VATS immediately, get everything, be sure that we've covered all the holes, make sure that there's a good wash, and leave 2 drains. And those are the things. We don't have any experience with the DPR. So yes, on the second scan, then it was really important, because now it was going to get messier to do a VATS, and that's what happened. Then it was a thoracotomy for decortication. Thank you.
Thank you. Supra?
I think the management you did was very good already. Nothing more to add. And like Dr. Fraga mentioned, I'm not quite sure about the DPR. In this case, it may have contributed to spreading the infection into the chest or not. This point I'm not quite sure, because I have no experience. But I think you did close the whole diaphragm before initiating DPR, right? So it shouldn't be the factor that caused the infection in the chest. Thank you very much.
Dr. Ferenc? I don't know if Sarah Asher.
I think I think with the diaphragm injury, you kind of have to consider that you have one cavity. It's not 2 separate cavities, like not a separate chest, not a separate abdomen. I probably still would have done DPR, but just extensively drain the chest, because you're just going to have a lot of effusion, and it's hard to get all contamination out in a perfectly watertight closure on the diaphragm sometimes.
Thank you. And then, of course, my mind goes to, in 10 years, are we going to use something equivalent to DPR actually in the thoracic cavity? Something thinking along the lines of a VersaFlow or a continuous infusion for contamination that you can just place the drains during the index case, and whether or not that would change anything. But that's that's certainly not standard of care and not something that we're doing right now. It's just something to think about. So
Yes, yeah. We actually, I spoke with the attending after the fact, and we talked about anything we could have done, and that was definitely something we retrospectively, we were thinking
I thought I
about.
just came up with that myself now. Okay, thank you. Well, it's nice to hear that your patient's doing marginally well, I guess, in the TICU. So nice save on that, and hopefully maybe you can give us an update shortly. At the next couple meetings, how he's doing. Anything else that you'd like to tell us or sum up with?
No, I think that's it.
Okay, nicely done. And I'm sorry, everybody, I wasn't expecting to moderate and getting the rocky start. And hopefully we'll be tighter for next week. So my apologies and thank you to everybody who offered their opinions and thoughts on this. Good job, Eugenia.
Thank you.
Thank you.